Appendicitis. Appendicitis is the most common cause of acute abdomen. About 7% of population will have appendicitis at some time in their lives. Male are affected more than females. The teenagers are more than adults. Although it can occur at any age, it occurs most frequently between the ages of 10 to 30 years. Pathophysiology. The appendix becomes inflamed and edematous as a result of either becoming kinked or occluded by the fecalith. Example, hardened mass of stool, tumor or foreign body. The inflammatory process increases intraluminal pressure, initiating a progressively severe generalized or upper abdominal pain that becomes localized in the right lower quadrant of the abdomen within few hours. Eventually, the inflamed appendix fills with pus. Clinical manifestations. Vague epigastric or periumbilical pain progresses to right lower quadrant pain and is usually accompanied by a low-grade fever and nausea and sometimes by vomiting. Loss of appetite is common. Local tenderness is elicited by at McBurney's point when pressure is applied. Rebound tenderness. Example, production or intensification of pain when pressure is released may be present. The extent of tenderness and muscle spasm and the existence of constipation or diarrhea depend on so much on the severity of the appendiceal infection as on the location of the appendix. If the appendix curls around behind the cecum, pain and tenderness may be felt in the lumbar region. If its tip is in the pelvis, these signs may be elicited only on rectal examination. Pain on defecation suggests that the tip of the appendix is resting against the rectum. Pain on urination suggests the tip is near the bladder or impinges the ureter. Some rigidity of the lower portion of the right rectus muscle may occur. Rousing sign may be elicited by palpitating the lower left quadrant. This paradoxically causes pain to be felt in the right lower quadrant. Rousing sign, ROVSINGS. If the appendix has ruptured, the pain becomes more diffuse. Abdominal distension develops as a result of paralytic ileus and the patient's condition worsens. Constipation can also occur with an acute process such as appendicitis. Laxatives administered in this instance may produce perforation of the inflamed appendix. In general, a laxative or cathartic should never be given while the person has fever, nausea or pain. Assessment and diagnostic findings. Diagnosis based on the results of complete physical examination and laboratory and X-ray findings. The complete blood cell count demonstrates an elevated white cell count. The leukocyte count may exceed 10,000 cells per millimeter cube and the neutrophil count may exceed 75%. Abdominal X-ray films, ultrasound studies and CT scans may reveal a right lower quadrant density and localized distension of the bowel. Complications. The major complication of appendix is perforation of the appendix, which can lead to peritonitis or an abscess. The incidence of perforation is 10 to 32%. The incidence is higher in younger children and the elderly. Perforation generally occurs 24 hours after the onset of pain. Symptoms include fever 37.7 degrees centigrade or 100 degree Fahrenheit or higher, a toxic appearance and a continued abdominal pain or tenderness. Management. Surgery is indicated if appendicitis is diagnosed to correct or prevent fluid and electrolyte imbalance and degradation. Antibiotics and intravenous fluids are administered until surgery is performed. Analgesics can be administered after the diagnosis is made. Appendectomy, that is surgical removal of the appendix, is performed as soon as possible to decrease the risk of perforation. It may be performed under a general or spinal anesthetic with a low abdominal incision or by laparoscopy. Nursing management goals include relieving pain, preventing fluid volume deficit, reducing anxiety, eliminating infection from the potential or actual disruption of the GI tract, maintaining skin integrity and attaining optimal nutrition. If there is possibility of peritonitis, a drain is left in place at the area of the incision. Patients at risk for this complication may be kept in the hospital for several days and are monitored carefully for signs of intestinal obstruction or secondary hemorrhage. Secondary abscesses may form in the pelvis, under the diaphragm, or in the liver, elevating temperature and pulse rate and increasing the leukocyte count. Otherwise, the patient is discharged on the day of surgery if the temperature is within normal. Thank you.